Good morning, ladies and gentlemen. Good morning. On behalf of UNAIDS, I'd really like to thank Strive and the consortium partners, DFID, colleagues from UNDP and SAT, for the opportunity to provide opening remarks at this important session. I'd also like to recognize Strive's important work to ensure a dedicated focus on addressing structural drivers of HIV. I was remarking earlier that I'm sorely disappointed that at the main meeting of this conference, of the plenaries, that there is nothing on structural drivers of HIV. And I think it's a missed opportunity if we're going to really change the face of what's happening around HIV on the continent, but also all over the world. Reflecting on the topic of my talk this morning reminded me of a quote by Nelson Mandela, whose 100th birthday was last week. He once said, "After climbing a great hill, we find that there are many more hills to climb. We have been climbing this epidemic one hill at a time. Now we must finish our journey, and we cannot lose anyone along the way." And I think this is key to understand that unless, for me, and for UNAIDS, that we address what we're talking about today, that we are losing people along the way, and we must make efforts to correct that. The Eastern and Southern African region is home to nearly 19.4 million people living with HIV, of which approximately 60% are women. We continue to have a feminized epidemic. Yes, antiretroviral treatment coverage has increased significantly, resulting in a reduction in AIDS-related deaths, with more women than men on treatment in most countries across the region. But of course, we have to note that adherence and retention rates are not where they should be. And also, just to start off with headlines, that Eastern and Southern Africa, 33% of the population is between the ages of 10 and 24. Those are the people we're talking about now. We have failed to date to turn off the tap of new infections significantly. And the very slow decline in new HIV infections of about 29% between 2010 and 2017 is uneven amongst countries and population groups. 1/3 of all new infections in the region occur in South Africa, and an additional 50% occur in 7 countries in the region: Kenya, Malawi, Mozambique, Uganda, the United Republic of Tanzania, Zambia, and Zimbabwe. We mustn't forget that key populations, including sex workers, men who have sex with men, transgender, and people who use drugs, also continue to have disproportionately high rates of HIV infection, and access to services does not meet the demand. Now, promises have been made, and promises were made in 2020, which is just around the corner, and being within reach for some countries. Those in ESSA, in this region, Eastern and Southern Africa, we're struggling to see if this long-held dream can become reality. We are simply not moving quickly enough to address the root cause of vulnerability at society level. In our region, 4,000 young girls and adolescents get newly infected with HIV every week. This translates to 23 new infections per hour. It's a very hard reality, just 2 years to reaching the 2020 timelines. And indeed, UNAIDS report that was launched just a few days ago warns that the pace of progress is not matching global ambition. And if we continue business as usual, and given the current rate of progress in our region, we estimate that we'll have a gap of about 340,000 new infections by the time we get to measuring again. I feel like I'm preaching to the converted, actually, because you all are experts in this area. But if I say that adolescent girls and young women aged 15 to 24 years are at high risk of acquiring HIV because of a combination of behavioral, biological, and structure factors, you understand what I'm talking about. I could also add that behavioral factors, risk factors, include many that you know: inadequate knowledge of how HIV is transmitted, inadequate knowledge about how to prevent infections, lack of knowledge of one's HIV status, low perception of HIV risk, high levels of unprotected sex, multiple sex partners, age-disparate relations, transactional sex, and early sexual debut. You know what we're talking about. But ladies and gentlemen, we have known these hard truths for a very long time. Yet if you go to national HIV programs, it's easy to see that the vast amount of resources are still heavily invested in biomedical interventions. This is simply not enough. The context of vulnerabilities is also rapidly changing. For example, the internet is now easily available through cell phone technology across the globe, and its penetration in countries in Eastern and Southern Africa has grown manifold in recent years. The surge in access to cell phones and to the internet has changed the means of communicating for obtaining sexual and/or romantic relationships, and has added a new dimension to the dynamics of transactional intergeneration sex. Just recently, we had a meeting with young people who are not usually involved in the HIV response, or they're just young people developing apps and working. And studies have demonstrated that we carried out that online sex seeking can often lead to risky sexual behavior. An estimated 65% of those who sought sex online in one study actually did end up having sex with a partner found on the internet, and of those, 44% did not use a condom during the last sexual encounter with an internet sex partner. We recently completed a rapid assessment of the most frequently used dating apps in the region and found that in the last 4 years alone, there's been a 2 times increase in searches for online sex. Let's also not shy away or underestimate the role of consumerism as a driver of transactional sex. In some countries in Eastern and Southern Africa, this issue has reached such a level that young girls who are in what are called blesser-blessee relationships are viewed as role models. Due to the unequal power relations and the toxic masculinities that drive such a culture, we know that biomedical interventions alone will not protect those in such relationships. Young people's experiences during adolescence lay the foundation for adulthood and define trajectories for future generations. One of the issues that we still haven't got our hands on in the region is really the issue of violence, sexual violence. Experiencing violence has a particular detrimental impact on women and girls' health, and this includes child marriage. Globally, although we have the figures of 1 in 3 women having experienced physical sexual violence, often at the hands of the intimate partners, in more than half of the countries in Eastern and Southern Africa, with recent age disaggregated data, young women aged 15 to 19 years reported a higher prevalence of recent intimate partner violence than women aged 15 to 49 years. In Namibia, for example, 52% of young women between the ages of 15 and 19 years reported experiencing physical or sexual violence by a partner in the previous 12 months, compared to 20% of women aged 15 to 49. In Eastern and Southern Africa, women who experience intimate partner violence are on average 1.5 times more likely to be living with HIV than women who have not experienced such violence. So you can see that violence remains a key driver. In South Africa alone, and I'm talking about old data, I was trying to look for something much more recent. In 2013, for those who remember the study that was conducted with Rachel Jukes and the MRC, 55,000 cases of violence were reported in 2013, and this was estimated to be 9 times lower than the actual number. Yet in 3 years that one study was conducted, only 34,000 survivors of rape presented at victim support centers. Violence, or the fear of violence, can make it very difficult for women to insist on safer sex and to use and benefit from HIV prevention, treatment, care, and sexual and reproductive health services. And women living with HIV who experience intimate partner violence are significantly less likely to start or adhere to antiretroviral therapy. And they have worse clinical outcomes than other HIV-positive women. It is clear that we cannot prevent new HIV infections without addressing gender-based violence. It's extremely important to address the sexual, reproductive, and health right needs of young girls and women. Across 41 of 56 countries with available data over the period of, I think it's about 2012 to 2017, the percentage of young women, 15 to 19, who had access or who had their demand for family planning satisfied by modern methods was lower than the percentage of women aged 15 to 49 who had their demand for family planning satisfied by modern methods. Age of consent legislation continues to create barriers, particularly for adolescents and young women. And this together, after all these years into the epidemic, discrimination by healthcare workers, law enforcement officers, teachers, employers, parents in households, religious leaders, and community members prevents young people living with HIV and key populations from accessing services for both HIV and SRH. Across 19 countries of having done the stigma index, 1 in 5 people living with HIV responding to surveys reported being denied healthcare. That is just not acceptable. And 1 in 5 people living with HIV avoided using or visiting a health facility for fear of stigma related to their HIV status. I'd now like to take some time to focus on what can be done. And you know a lot of this yourselves. Sometimes the barriers can seem very insurmountable and their impact disheartening. But for every challenge, there are also reasons to be hopeful. Multiple solutions exist for every challenge. Comprehensive prevention is something that we're still pushing for adolescents and young women, and it must be delivered on understanding the context, both the geographical patterns, HIV and HIV risk, and implemented at sufficient scale and intensity. We were talking earlier with Jonna about the batik approach, where there are lots of projects, all doing very meaningful stuff, but it doesn't all come together, ensuring a combination of prevention interventions. Combination prevention is definitely what we are calling for. Primary prevention, like condom promotion and distribution, inclusive social and behavior change communication programs, school-based HIV prevention, including comprehensive sexuality education, which still remains heavily contested by parents and politicians, are recommended. Keeping girls in schools and reaching boys and men with testing and treating and the voluntary medical male circumcision still help to prevent new infections. But prevention programs must be broader. They must be influenced by policy reform and social interventions. And of course, you're aware of the cash transfers and social grants, which have really worked in many places. But we must also work to remove legal and policy barriers to the use of services for HIV and sexually and reproductive health by adolescents, by guaranteeing privacy and confidentiality, which in many places is very difficult to uphold, and by removing age-related barriers. Then the uptake of prevention services, even for things like contraception and testing, must be increased. There is urgent need to address the intersections between HIV and gender-based violence, and we must ensure that we leverage the synergies in designing programs that include not only giving tablets and condoms, but includes addressing the issues around why people would or wouldn't. So we certainly have opportunities. Today, there's a publication which is a result of a partnership between Strive and UNAIDS. It's got Strive, UNAIDS on the back. And those people will understand why I've put that up. But it's Transactional Sex and HIV Risk from Analysis to Action. This publication, and you'll learn a little bit more as we will distribute it later, is a good example of how we can work together to move from research to policy. The Global HIV Prevention Coalition, which, as you know, was formed towards the end of 2016, have mobilized around strengthening HIV primary prevention, and that is great. It has renewed political commitment, and I really hope that strong partnerships with an institution like Strive and the consortium members to ensure that these efforts translate into impact take place. Of note, and I am speaking as UNAIDS, is that the Global Prevention Coalition is still a focus on the biomedical interventions. So your partnership in trying to advocate for that would be highly recommended. UNAIDS is using evidence to develop policy and program guidance, and we build on this relationship that we have with you and research partners and countries and communities to make sure that moves forward. And then, of course, there's a lot of work with Global Fund, which has pushed forward catalytic funding for 13 countries for strengthening programs to address adolescents, girls, and young women and human rights. DREAMS, which I'm sure you've all heard about, a PEPFAR program implementing comprehensive preventions, and countries are being urged to take up the program. And of course, countries like South Africa are moving forward with examples like She Conquers in South Africa. We've also got a lot of support in the region from Sweden, which has funded programs to accelerate SRH and HIV linkages through the first joint UN program with UNFPA, WHO, UNICEF, and UNAIDS. And the UN Secretary General himself has put forward the Spotlight Initiative on gender-based violence, linking this to SRHR in several countries in Uganda, Malawi, Mozambique, and Zimbabwe. Of course, there are others like the UK's Initiative on Women and Peace, and just into the intergovernmental organizations, SADC, the Southern Africa Development Community, and most recently, the East African Community, are taking regional leadership to provide an entry point for developing policies that are evidence-informed and human rights-based. And for SADC in particular, the active involvement of adolescents and young women and the key populations in the development is a huge step forward in recognizing that these programs need to be developed together, because community engagement is critically vital, and communities are able to mobilize and call on support structures that they need to make change. And anything that we develop can only have meaningful impact with communities. So I'm making a plea for engaging adolescents and young women to inform what we plan to do. Addressing the structured drivers and working on HIV prevention is a long march requiring sustained efforts, and we need to continue to keep the global attention on the prevention agenda and make sure that it's inclusive of the issues that we're talking about. The research that you're doing shows that addressing gender inequality, the social norms, the intimate partner violence, alcohol, stigma, and transactional sex are as important and real as any biomedical intervention in addressing the HIV epidemic, and they deliver measurable results. These results go beyond the HIV response and continue to overall development and improve health and equality. And I think it's the responsibility of political leaders and governments and the international community to make sufficient financial investments and establish the legal and policy environments needed to bring the work to scale. Ladies and gentlemen, the returns on investments in young people, particularly young women and adolescents, and in the eastern and southern region, adolescents and young people, as I said, aged 10 to 24, form nearly 33% of the total population, can be enormous, with the ultimate potential to catapult these economies towards eliminating extreme poverty. By doing so, we will create the momentum to reach the fast-track targets by 2020, although I think 2020 is just around the corner. Actually, we've missed the boat. And I'm afraid that I hope that by the next time we get together, we're not still talking and trying to move forward the agenda, because 2020, Eastern and Southern Africa is not meeting its political declaration targets. I thank you for listening, and I'm wishing you great deliberations today, and I'm looking forward and hope we can push something in plenary. It's never too late. We must find the opportunity to galvanize the whole community that's coming around to Amsterdam this week to talk and understand what it requires to end AIDS by 2030. Thank you very much.